We looked at estimating creatinine clearance using the Cockcroft-Gault equation. Now, the next learning objective is explain the mechanism of action and toxicodynamic properties of aminoglycosides. Most aminoglycosides are natural products that naturally exist in nature, and the naming of these aminoglycosides are actually based on the organism that they are derived from. So streptomycin, neomycin, and tobramycin are actually derived from Streptomyces species. We also have gentamicin, which is derived from Macromonospora species. We also have a couple of aminoglycosides, amikacin and polysomycin, that are semi-synthetic derivatives. So these are actually developed in the lab. Aminoglycosides are available as IV formulation, with the exception of neomycin, which is available as PO, and there is also a cream formulation. Aminoglycosides have concentration-dependent rapid bactericidal activity against gram-negative organisms. They inhibit protein synthesis by primarily binding to the 30S subunit of the ribosome. In this picture, we're looking at a typical bacterial cell. You can see that inside the cell there is a circular chromosome along with multiple plasmids. There are also multiple ribosomes. In prokaryotes, we have 70S ribosomes. So all of these 70S ribosomes are floating inside the cytoplasm. Now, the 70S ribosome is the primary site of action of aminoglycosides. The 70S ribosome consists of a 50S subunit along with a 30S subunit. Aminoglycosides in particular bind to the 30S subunit. The function of the ribosome is to translate messenger RNA into a polypeptide. So these amino acids will come into the ribosome and, based on the genetic code, form a polypeptide chain. An aminoglycoside will interrupt this translation process. Now, note that ribosomes are inside the cell, and in order for aminoglycoside to work, they actually need to go inside the cell first and then find this ribosome and inhibit protein synthesis. In this picture, we're looking at the cell wall of gram-positive and gram-negative bacteria. The primary difference between gram-positive and gram-negative organisms is the outer membrane that exists in gram-negative organisms. So there are two layers in gram-negative cell wall. There is the plasma membrane, followed by a tiny layer of peptidoglycan, and then the outer membrane. Gram-positive organisms, on the other hand, they have the plasma membrane followed by a thick layer of peptidoglycans, and there is no outer membrane. And because there is no outer membrane, this peptidoglycan layer can actually grow and get thicker. The reason this is significant is because aminoglycosides are polar and they cannot penetrate through the peptidoglycan layer. In order for them to get inside the cell down here, they actually need to use either porine channels or use carrier proteins. In other words, aminoglycosides cannot simply penetrate through these layers. Therefore, aminoglycosides are active primarily against gram-negative organisms because they can go through these porine channels, and there is a tiny layer of peptidoglycan that they can go through, and then they can go through more porins and get inside the cell where the ribosomes are. When it comes to gram-positives, because aminoglycoside cannot get through peptidoglycan, they do not have activity against gram-positive organisms on their own. However, we can use aminoglycoside for synergy with other antibiotics, and those other antibiotics typically are active against peptidoglycan layers. So if the other antibiotic will break down this peptidoglycan layer, then and only then aminoglycoside can get inside the cell and act on ribosomes and give synergistic effect with the other antibiotic. Now, when we look in more details of what happens when aminoglycosides bind to the 30S subunit of the ribosome, you can see that the first thing is that they block initiation of protein synthesis. And if protein synthesis has already initiated, they can block further translation and actually cause premature termination of translation. They can also cause incorporation of incorrect amino acids into the protein product. Now, when it comes to the spectrum of activity of aminoglycosides, and this is in general for all aminoglycosides, for gram-positives, it is essentially synergistic activity. So especially for enterococci, for some infections such as endocarditis, they are used for synergistic activity with other antibiotics, specifically with beta-lactams. The same for Staphylococcus aureus. But their true activity is really in gram-negative arena. So H for Haemophilus influenzae, so they have great activity for protease, E. coli, and Klebsiella, and of course for Capes organisms, and that's in general. So Citrobacter, Acinetobacter, Providentia, Enterobacter, Serratia. Now some of these can develop resistance, for example Acinetobacter, but there's a good chance that aminoglycosides will be active against these organisms. Now with Pseudomonas, I have put a plus minus because really the anti-pseudomonal aminoglycosides is tobramycin and plazomycin, and I'll talk more details about the anti-pseudomonal activity of aminoglycosides shortly. And they do not have activity against any anaerobes or atypical bacteria. Now in 2023, CLSI breakpoints updated. So prior to 2023, in up to 2022, there were breakpoints for susceptible, intermediate, and resistant for Enterobacterialis and Pseudomonas. What happens in 2023 was that because these breakpoints were pretty old, so they've been around since 1980s, and they hadn't been really updated, and we know much more about pharmacokinetics and pharmacodynamics of these agents nowadays. So the committee updated. So what they did is that they actually lowered the breakpoints for Enterobacterialis. So previously an MIC of 4 or less was considered susceptible for gentamicin and tobramycin. That has been lowered to less than or equal to 2. And this is assuming, the most common dosing nowadays is 7 milligram per kilo once a day. And this regimen is really designed to get an MIC of around 2, or I should say concentration of around 2. So an MIC of 2 or less was decided, based on many factors, including the dosing we use and the pharmacokinetics and pharmacodynamics, as well as clinical studies that are out there. Now for amikacin, the susceptible breakpoint was less than or equal to 16, and it is now less than or equal to 4, and that's based on 15 milligram per kilo once a day. Plazomycin, which is the newest aminoglycoside, came to the market in 2018. Previously, we did not have CLSI breakpoints for them. So now there are added, so less than or equal to 2 is considered susceptible for plazomycin. And this is for all types of infections. Now, with regards to Pseudomonas aeruginosa, previously, we had susceptibility breakpoints for gentamicin, tobramycin, and amikacin. What happened in 2023 is that gentamicin, given the distribution of MICs among Pseudomonas isolates and the PK/PD of gentamicin, it is no longer considered active against Pseudomonas. So in fact, there are no criteria for susceptibility for gentamicin in regards to Pseudomonas. So it was actually removed. In other words, if there is a sample sent to the micro lab, they should not be testing it against gentamicin. So you should just consider that resistant. They will not be testing to report it as either susceptible, intermediate, or resistant, because it will just not be susceptible. So we should just consider resistant. For tobramycin, the breakpoint was reduced from less than or equal to 4 to less than or equal to 1, and that is based on the dose that we can use safely in patients, because if we increase the dose, we can cause unnecessary toxicity. And with amikacin, it has remained the same. The only thing that has changed is that this is only good if you are using it for a urinary tract infection. So if you have Pseudomonas in the urine, we're going to get, using 15 milligram per kilo once a day dosing, we're going to get enough concentrations in the urine, but not anywhere else in the body. So for any systemic infection, amikacin is no longer considered active against Pseudomonas. And with plazomycin, which is again the newest agent, we didn't have susceptibility breakpoints before, and we still don't. So for Pseudomonas, we still don't have criteria for plazomycin. Now let's take a look at toxicodynamic properties of aminoglycosides. So as we discussed, aminoglycosides bind to the 30S subunit of the ribosome and inhibit protein synthesis, and this can also happen in mitochondria, so it can lead to mitochondrial toxicity, which can affect the host. Specifically, this can lead to toxicity in the kidneys, in the ear, and in the nerves. So nephrotoxicity is a big issue with aminoglycosides, and in general nephrotoxicity is considered somewhat reversible, and it is dose dependent. So the higher the dose, the longer we use aminoglycosides and the more frequently we use it throughout the day, increases the risk of nephrotoxicity. And between the three agents that we use, amikacin, gentamicin, tobramycin, the rate is somewhat similar, but higher than streptomycin. So streptomycin is less nephrotoxic. Risk factors for nephrotoxicity includes increased age, pre-existing renal disease, use of diuretics, exposure to radiographic contrast, circulating volume depletion, and use of other nephrotoxic medications, including ACE inhibitors, NSAIDs, amphotericin, or cisplatin. Next, we have ototoxicity, and we can think of ototoxicity in two subcategories. So one is vestibular toxicity and one in cochlear toxicity. So vestibular toxicity essentially leads to dizziness, ataxia, and nystagmus, and especially with IV or parenteral use, patients typically develop acute bilateral vestibular loss, and these patients will be unable to stand unaided. And these are essentially considered permanent because of the apoptosis of the hair cells in the ear, in the vestibular and cochlear, is essentially irreversible. Now, vestibular toxicity is more with streptomycin than gentamicin and tobramycin, and it has not been reported with amikacin. So now cochlear toxicity is what leads to tinnitus and hearing loss, and amikacin does have this toxicity. So amikacin and tobramycin can lead to cochlear toxicity, but rarely gentamicin. So gentamicin and streptomycin mostly cause vestibular toxicity as opposed to cochlear toxicity. Now, there are some genetic component to this, so there are certain pharmacogenomic characteristics that essentially makes certain patients more susceptible to these toxicities. Now, lastly, we have neuromuscular blockade, which is very rare, and this is essentially happening with amikacin, gentamicin, and tobramycin. And fortunately, muscular blockade can be reversed by administration of IV calcium. And lastly, there are situations where we use a single dose of aminoglycosides, and it's good to know how safe a single dose is. So for example, sometimes we can use a single dose to treat gonorrhea. We can use a single dose to treat cystitis due to resistant organisms, and for prophylaxis prior to surgery or invasive procedures. And a systematic review of 36 studies, which included 11 randomized controlled trials, showed that a single dose of gentamicin, it can have an effect on renal function, but it's really considered mild and transient. So it's really not considered nephrotoxic in the sense that it will damage the kidneys. And there were no cases of ototoxicity associated with just a single dose of aminoglycoside. So, just a single dose is pretty safe. And, especially when we're waiting for susceptibility results to come back, it is okay to use aminoglycosides empirically, but we should streamline and switch to better options as soon as possible. Now let's take a look at aminoglycoside allergic reactions. In general, allergic reactions to aminoglycosides are extremely rare. In fact, no allergic reactions to plazomycin, which is the newest aminoglycosides that came to the market in 2018, has been reported. Most reported reactions occurred in children or patients over 55 years of age, so most patients will not have any allergic reactions to aminoglycosides. And the most frequently reported type of allergic reactions are cutaneous, so things like allergic dermatitis, contact sensitivity, ulcerative dermatitis, urticaria, rash. And there could occasionally be some serious cutaneous reaction like TEN and DRESS. And anaphylaxis has been reported from parenteral use. When it comes to aminoglycoside allergies, it's helpful to think of aminoglycosides in two main structural classes. So streptidine, which is only streptomycin in this group, and the rest of aminoglycosides, some of which are not listed here, belong to deoxystreptamine group. So those are structurally similar, whereas streptomycin is structurally unique. And what we have found is that cross-reactivity among aminoglycosides with deoxystreptamine group is at least 50%, and therefore all streptamine aminoglycosides are contraindicated in patients with hypersensitivity to another deoxystreptamine aminoglycosides. Whereas cross-reactivity between deoxystreptamine aminoglycosides and streptomycin has not been observed. So because streptomycin toxicity, in general, we don't use streptomycin except for patients that really need an aminoglycosides and they have an allergy to one of the aminoglycosides. For those patients, streptomycin is an option.